Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Michael Krasovitsky. I'm a medical oncologist at St Vincent's Hospital in Sydney and a senior academic lecturer at the University of New South Wales. Prior to commencing, I'd like to note that the Thoracic Oncology Group of Australia acknowledges the traditional custodians of the land on which we live, work and practice. We pay our respect to their elders past, present and emerging, and we extend that respect to all Indigenous peoples, including those listening to this podcast. Today's episode is going to be an absolute cracker. We're exploring lung cancer in older Australians, and I'm so pleased to have some wonderful colleagues joining me today who I'll take a moment to introduce. So I'd first like to introduce Professor Christopher Steer, a medical oncologist at Border Medical Oncology and Associate Professor at the University of New South Wales. Welcome, Christopher.
Thank you very much, Michael. It's an absolute pleasure to be here.
I'd next like to introduce Professor Shalini Vinod, a radiation oncologist at Liverpool Hospital and a conjoint professor at the University of New South Wales, also an honorary professor at the University of Wollongong. Shalini, thank you so much for joining us.
Great to join, and thanks for asking me, Michael.
Of course. And finally, Nicole Webb, a cancer care coordinator at Albury-Wodonga Health and clinical research nurse. So happy to have you join us, Nicole.
Thanks, Michael. It's great to be here.
And to all of you listeners, welcome to TOGA's Conversations in Lung Cancer Research podcast. Today, we're going to be focusing on lung cancer in older Australians. And I thought we'd start with a little bit of background about why we're all here and the role that we play in looking after older people with cancer. And that role is as part of a holistic field of care, which we refer to as geriatric oncology. Geriatric oncology is a subspecialty within medical oncology, radiation oncology, and cancer services more generally. It's also an oncologic approach, and it focuses on the intersection between aging, cancer, and health for older individuals. It brings together what we all do, a comprehensive oncologic assessment, with a geriatric assessment, and creates an informed approach to the individual's cancer treatment and their diagnosis. It recognises the impact that ageing and age-related strengths and vulnerabilities may have on cancer, its diagnosis and treatment, and simultaneously recognises how cancer, its diagnosis and treatment may impact on ageing and age-related strengths and vulnerabilities. It is a multidisciplinary and multi-pronged field of oncology, and I look forward to discussing it in more detail today. With regards to thoracic cancers in particular, we all know that thoracic cancers are the leading cause of cancer death in Australia. Our optimal treatments are informed by clinical trials. However, much of our data is informed by the biology of younger individuals. The median age of a lung cancer diagnosis in Australia is 72, but most oncologic trials do not reflect this. For example, in the pivotal phase 3 Keynote 189 study, the median age of participants was 65, while for the WJTOG 0205 study, the median age was 63. And what that means is that most of the data that we're using to inform our decision-making is actually not relevant to the patient in front of us. Indeed, a fantastic colleague of mine, Dr Monica Tang, published a piece in Lung Cancer in 2022, where she noted that only about 30% of patients with lung cancer would have been considered trial typical and made it into the pivotal clinical trials. We know that for older people, standard trial tools such as the ECOG performance status score may not be appropriate. And in fact, only this week, a fantastic article by our colleagues, Dr. Wheeler in JCO, noted that there is an ethical imperative to include older people in clinical trials and to use endpoints that are meaningful for this population over and above the classic endpoints of PFS and OS. I really recommend that article. And that's where we fit in, and that's where geriatric oncology informed care and trial design come into play. As the largest cohort of patients with cancer, we need to understand more about the specific needs of individuals of older age and tailor our treatments to their needs. And this is not just our opinion. This is supported by almost every international oncology organisation. ASCO, ESMO, ASTRO, EHA, the list goes on. We know that using an age-informed approach improves virtually all outcomes in cancer, improving physical fitness, health-related quality of life, physical function, social function, and in some cases, improved survival. It is a medical necessity. One final comment before we get to our fantastic discussion is that on ageism. And when we consider the needs of older people with cancer and the way that our systems and trials are set up, we have to consider the part that ageism plays. And ageism has many components, but essentially reflects how we think of, feel about, and act towards older people. And I'd encourage all of our listeners to just contemplate at the moment what kind of thoughts go through their head when an older person comes into the clinic. Ageism can occur on multiple levels and is typically negative, though may have a positive component. It's real and we all carry it with us. It's our responsibility to notice this, to take responsibility for it, and to act on it. And now that my spiel is done, I have the fantastic privilege of speaking with my colleagues who I adore and respect and admire. And I'm going to start with you, Christopher. Could you just tell me, I guess, a little bit about your approach to assessing a patient through a geriatric oncology lens? And perhaps you could talk to us about some of the tools that you use.
Thanks very much, Michael. As you know, my mantra is adequate assessment yields appropriate care. In the adequate assessment of older adults with cancer, it is so vital, as you say, to get a complete picture so that you can deliver the person-centred, age-friendly care that they deserve. The adequate assessment requires geriatric assessment tools, and there are a number of those which we can use. Before I say that, I'll say that there's no exact definition of an older adult, but as we know, comorbidities and issues that can complicate cancer care are more common as you get older, and often in our setting that would be above the age of 70 years. The assessment tools that we use at the Albury-Wodonga Regional Cancer Centre include a two-step approach using a screening tool such as called the G8 or the Geriatric 8. 8 questions which give you a snapshot of the patient's status. It's based on the mini nutritional assessment with a couple of added questions, including a question about self-rated health. The beauty of the G8 is it's quick. It gives you a score, and if you score less than or equal to 14 on this tool, we then go on to a more formal geriatric assessment process, which is multidimensional, includes aspects you normally wouldn't discuss in a medical oncology consultation, such as cognitive assessment, mobility, vital assessments that you need to do for your older adults to deliver that appropriate care. So the electronic geriatric assessment that we use, or the ERFA, is now standard as part of what I call enhanced supportive care program that I'm sure Nicole, who is our geriatric oncology champion at our centre, will help guide us through. There are other tools such as the VES13, which is also available on EviQ, thanks to your hard work, Michael, and the hard work of others. So if people are interested in finding the tools, they are there for you on EviQ. And then on a global level, my final point will be that ASCO, the Cancer and Aging Research Group of the US, and SIOG, the International Society of Geriatric Oncology, are working together to produce the practical geriatric assessment. It's a pragmatic, practical tool that forms part of the ASCO guidelines that do suggest and recommend that in patients above the age of 65 years of age, even being considered for cancer care, cancer treatment, they should undergo a geriatric assessment. And the PGA is there, it's available, it's going to be included in EPIC, it's going to be on REDCap. There's all sorts of ways in which we can go and access this important tool, which then can help deliver better care.
Thank you so much, Christopher, and an absolute shout out to our colleagues at ASCO and SciOg for putting together that geriatric oncology assessment. It's easy to use, it's certainly user-friendly, and I think it really does enhance the care that we can give older people. I'd like to move on to Shalini. Shalini, older people with cancer can present clearly in a myriad ways, but we do note that older people are at high risk of frailty or pre-frailty. And I'm wondering if you can tell me what those terms mean to you and how that may factor into your decision-making.
Thanks, Michael. The frailty is a condition that's associated with aging, and really it manifests as an increased vulnerability of the patient to stresses because there is a decline in their physiological reserve and depletion of energy resources. So there are a few scales to measure frailty. So I'll just mention a couple. For example, there's something called the Clinical Frailty Scale, which has 9 categories. And this is really good because it's got little pictures of the patients and you immediately can get an idea of where they fit on the scale. But this takes a holistic view, combining features such as whether the patient is slowing down, if they're needing help with activities of daily living, or if they are fully dependent on personal care. There's another one that's called a Fried phenotype, which is based on five criteria. And if you have 3 or more of these criteria, then you are considered frail. And this includes slowness, which is measured by gait speed, weakness that's measured by hand grip strength, weight loss, exhaustion, and low physical activity. Now, in terms of the spectrum from fit to pre-frail to frail, I guess fit people are those who are robust, who are independent. They may well have some medical problems, but these are well controlled. The pre-frail people are those who remain independent, but it's when their symptoms are starting to slow them down and limit their activities. And then once you, in terms of frailty, that's when the people are getting slowed down and needing help from others with the activities of daily living or personal care. Now, some of this may well be reversible, particularly if this is due to non-cancer causes. And there's certainly evidence to support prehabilitation for patients undergoing lung cancer surgery or even radiotherapy. Measuring frailty or deciding where the person is on this frailty scale does impact on treatment decisions, because we know that frailty is linked to mortality, hospitalizations, and treatment toxicities. And the last thing I'd want to do is recommend treatment that will adversely affect the patient and may result in a loss of independence or further dependence. So once you know where they are on that scale, you can have a shared decision-making process to discuss the pros and cons of a particular treatment regimen, and then I guess collectively decide on the most appropriate course of action. And I guess in terms of the radiotherapy context, if you're going down the frail pathway, we might be discussing, say, rather than concurrent chemoradiotherapy, maybe radiotherapy alone, maybe a shorter course of radiotherapy, or even perhaps a palliative rather than a curative approach.
Thank you so much, Shalini. That was so insightful and so helpful. And look, I think you've made an extremely important point there that these syndromes are not static, and repeated assessment of function and repeated assessment of frailty is really important, because we know that many of our patients with advanced cancer will develop frailty. Nicole, over to you. Look, data suggests that older individuals with advanced cancer prioritize quality of life over quantity or length of life. Certainly not a universal truth, certainly not. How do you discuss quality of life with older individuals, and what have patients told you is important?
Thanks, Michael. Yeah, quality of life is an interesting topic, and it's something that is absolutely essential that as healthcare workers, I think we're aware of, and that we actually ask the patient what quality of life looks like to them. So one of the ways that we do that here, and we actually trialed a This Is Me tool, which Mai Krishnasamy and her team developed, is ask the question, there's a question in the tool, quality of life is more or less important than length of time. And the patients that we asked that question to in a small study that we did here showed, I think 100% of them answered that quality of life was more important. So like you say, not certainly universal, but I think it's a very common.
Getting close to.
Yeah, getting close to. And so when I go to do our geriatric assessments on patients, I explain to them that a really important part of the assessment involves understanding them as a whole person, but finding out what is important to them. And so, some living long, the extension of life can often come at extreme costs, and that can involve lots of extra time in hospital and extra suffering. And so finding out really what's important to the patient can then help us as clinicians and the doctors as well provide the most appropriate treatment. Some of the patients that I've dealt with, some of the farmers, for them, spending time hours and hours in hospital versus, what they've done all their life, which is spending heaps of time outside, that is their quality of life. And for a lot of the older people that I deal with, taking that holiday as opposed to spending heaps of time in the treatment chair. But the other thing that's also important is making sure that they're informed. So doing the assessment, understanding their situation, but then making sure that they've got all the information, because not all treatment involves hours and hours in chairs. And I'm sure we'll hear more from Christopher, but there are some other options treatment-wise. So I think making sure that patients understand what's important to them, what matters most, and then making the decisions based on that. And I would like to add there that for some patients, quality of life, not a lot of the time, but it's not infrequent to have patients raise that as an option as well. And often that is because the idea of suffering is a horrible thing for them, so that they want to make sure that they've got all those options and explore all those options and potentially have that set up as an option as well.
I agree with everything you've said, and you've said a couple of really important, well, everything you've said is important, but certainly that question, what matters most, really just a fundamental component of all oncologic care, but particularly important for older people. And just to comment on the VAD, and I'm not sure if my colleagues want to comment, but we talk so much about quality of life, and I think we often forget about quality of death. And that's something that our patients really think about. How am I going to die? Am I going to die uncomfortably? And I think when we're conceptualizing what matters most, we should be pondering how that individual feels about dying and the circumstances around their death. Now, just a small question for Professor Steer, just a little one, just taking the bottom of the tray. Chris, what do you think about when you're prescribing systemic therapies to older individuals, particularly with lung cancers or thoracic cancers? And in the context of aging, are there physiological changes or risks that you think about?
Yes, so of course, when we are thinking about treatment for our older adults, the adequate assessment does look at what matters most to them. And as you've discussed previously, maintenance of independence is something that we have to think about. And sometimes that means possibly the most appropriate treatment for the patient is no treatment. The other issue about the adequate assessment yields is that it guides your supportive care. We know that older adults are more vulnerable to the complications of our therapy for various reasons potentially. And that's one reason why I call our geriatric oncology service Enhanced Supportive Care Clinic, because it's all about assessing and then providing that supportive care. Now, why and how do we need to do that if we are embarking upon active treatment? Let's say patients with lung cancer using platinum agents are commonly still the standard of care for many patients with this disease in combination with drugs such as taxanes. And we'll talk about immunotherapy in a moment. But the common drugs cause toxicity such as neuropathy, and if you've got pre-existing neuropathy or various degrees of decreased mobility, you're going to be at increased risk of falls. And falls is a key part of the geriatric assessment, trying to work out whether the risk of that and then minimising it. And you don't want to increase that if you're using drugs which impair neurological function, obviously. So there are a number of high-risk medications, such as the platinums and the taxanes, which can increase the risk of that. We do know, we can't assume actually that overall function does decrease with age, except for one example, and I think that is bone marrow function. I think bone marrow function does decrease as you get older, and there are studies to suggest that using agents which, such as growth G-CSFs and filgrastim, pegfilgrastim, are beneficial in patients over the age of 65 receiving bone marrow toxic treatments. So as part of the supportive care, you do need to think about that to minimise the bone marrow toxicity. But apart from that, if you're talking about kidney function, liver function, you really just need to assess it and change your treatment accordingly if you detect it. But that's part of general oncology care. When it gets to using the geriatric assessment to guide your treatment, well, there are good phase 3, level 1 evidence, randomised controlled trials of geriatric assessment guiding your treatment. And we know that the geriatric assessment reduces the risk of toxicity in patients receiving treatment who are older. And one of the reasons in which they do that is by upfront dose reductions. 10 to 20% dose reductions in the patients you identify as being frail and vulnerable on your geriatric assessment leads to better outcomes without impairing survival, particularly in these patients who are treated with palliative intent with chemotherapy. So upfront, do not be scared of upfront dose reduction in patients who are frail. It's basic rule of thumb, but the randomised evidence tells you that if you do the geriatric assessment, you're more in tune to those issues and you're much more likely to do it, and everybody wins. So geriatric assessment is a cornerstone of the reduction of toxicity of your patient's treatments. I did mention I was going to talk about immunotherapy. We don't have a good tool such as the Cancer and Ageing Research Cancer and Ageing Research Group chemotherapy toxicity tool for predicting immunotherapy toxicity. And older adults are not at risk of increased risk of immunotherapy toxicity. However, they would be at increased risk of suffering from possibly the minor levels of toxicity that immunotherapy brings, and also possibly from increased risk of toxicity from the steroids that you might need to treat the immunotherapy toxicity. So immunotherapy in older adults is something for another day potentially, but there's not an increased risk of toxicity, and they respond just as well as younger people. So they're still, as we all know, very active agents. They just have different considerations, and as always, adequate assessment yields the appropriate care and enhanced supportive care of these people.
Thank you so much, Chris. You're reminding me of a patient of mine who had relapsing immunotherapy arthritis, and we couldn't quite understand why it wasn't getting better despite prednisone. And I'm not sure if everyone's aware, but the prednisone bottle has a cotton bud at the top, and it's actually quite annoying getting that cotton bud out for anyone. But her arthritis and her lack of social supports meant that she actually couldn't get that cotton ball out from the top, so she wasn't taking her steroids. Just such a minor thing we wouldn't think about, but once we got the cotton bud out, things got better. And I think as oncologists, we're probably a little bit frightened of deviating from standard protocols, but we always do need to remember that the person in front of us is not a number in a trial. They're a person, and dose reducing at the outset may very well be appropriate. I think in contrast to medical oncology, I have to say I think our radiation oncology colleagues are very proactive in geriatric oncology research, and certainly at adjusting treatments depending on an individual's frailty and stage. And I wonder if I can move to you, Shalini, and you could tell us a little bit about the practicalities of radiation in older people and what some of your considerations are when prescribing radiotherapy to an older person with a thoracic cancer.
Yeah, thanks, Michael. Look, in general, radiotherapy is probably better tolerated than systemic therapies, and many radiotherapy trials have included older patients. So, for example, the TROG-Chisel trial, which was looking at stereotactic radiotherapy for lung cancer. The median age in the two arms was 73 and 77. However, treatment can still cause significant side effects, especially when it involves sites where there's mucosa, so the management of head and neck cancers and pelvic malignancies. So in these settings, we have to be quite proactive in providing supportive care to get patients through treatment. But on the other hand, treatment to other sites, for example, early stage breast cancer, it's much more tolerable. And these days, in some of these patients, we can just give 5 fractions, 1 week of treatment, and it's all done with minimal treatment burden and toxicities. In terms of practicalities of radiotherapy delivery, you have to remember that radiotherapy is a daily treatment, usually given Monday to Friday. So people have to come in every day, which can be a chore and a burden, particularly if they are relying on others to bring them in. And they also need to be getting on and off a treatment couch. So there may be a false risk, and we have to assess patients, and indeed we do assess patients for this. And for frailer patients or those who might have mobility issues, we do actually allow a longer time, a longer booking on the treatment machine to just cover those access issues rather than assuming everyone can have this sort of standard slot. For radiotherapy, patients also have to be positioned comfortably in a reproducible position because they're in this position every day for a number of treatments over many weeks. A common position is when the arms are above the head. And for patients with arthritis in their shoulders, this can be a big problem. So we need to, ask about these things and then make them as comfortable as possible, including analgesia as needed. The other part of radiotherapy is the therapists do give patients instructions. They are communicating via a microphone to the patients who are inside the treatment room. But we need to know about if the patient has sensory issues related to sight and hearing. So we need to ask about this in advance to see if the communication has to be altered in any way to help. Having said this, radiotherapy is a really safe, and non-invasive and effective treatment in older people. And the best example of this is stereotactic ablative body radiotherapy for early stage lung cancer. And studies that have implemented this have shown that it's reduced the proportion of older people not having any treatment for their lung cancer and actually increasing survival at the population level. And this has been shown in a Dutch study, a population-based Dutch study. The other options, the other thing I was going to say is stereotactic body radiotherapy can also be used for treatment for metastases at particular locations and may delay the requirement for systemic therapies, which is also a bonus in these patients. Apart from that, we can often hypofractionate, and by that I mean we give a slightly larger dose per fraction over a shorter time period to condense the radiotherapy, and that's also a good option, particularly in older patients and usually in the setting when they're not having systemic therapy. I guess in terms of toxicities, I think I've already mentioned this before. It's usually those locations where there's mucosa, head and neck, esophagus, pelvis, getting mucositis, esophagitis, cystitis, diarrhea, all these things that may result in poor oral intake, dehydration. Even something like frequent trips to the toilet could be a false risk. So where we are expecting those toxicities, I think we have to be quite proactive and ensure that there are some carers around, or if there aren't, what can we do to sort of mitigate those side effects? Yeah.
I've never actually thought about all the transfers that would be needed onto the radiotherapy bed. You're right. You're opening up lots of risks there for falls, and that's why we're so lucky to work in multidisciplinary teams with physicists and technicians who can help with all of that. And Nicole, I'll move to you next as we sort of begin to think a little bit more about systems and ageism. Older people may need additional supports when they're going through a cancer journey. And I'm wondering if you can tell us some of the kind of practical, day-to-day and psychosocial supports that we should be discussing more with older people.
Yeah, great. Thanks, Michael. First of all, the importance of an enhanced supportive care so that we can actually have proper time to raise with patients what some of their concerns might be. I'm just going to think about a patient who has lung cancer. He's had radiation and chemotherapy here, and currently may be having a recurrence. He's having some imaging around that. When he came to us, one of the questions that we ask with our enhanced supportive care assessment is what level of education a patient has got to. What is your highest level of education? And his highest level of education was primary school, but he said, actually, I've only had 1 year at school in my entire life. He's held down multiple jobs, and he's quite an intelligent man who somehow has managed to get through a lot of life with very low levels of literacy. And so we were able to, he also lives 2 hours away, and he's on an age pension. There's multiple psychosocial factors there that could impact on his ability to access treatment. We were able to basically case manage him, organise all his transport, arrange his accommodation here whilst he had his 6 weeks of treatment, attend all his appointments, brochures, booklets that were of no use to him. So we really had to make sure that we spent enough time talking to him, and he had enough time to have his questions answered with the doctor. And I must just give a shout out to all the supportive care organisations out there. Without the Cancer Council car, without Can Assist, they paid for his transport. VIPTAS, actually it was VIPTAS, he's from New South Wales, who were able to help bulk bill his accommodation costs in our local Hilltop patient accommodation. Without all these different organisations all working together to support this patient, I don't think he would have been able to get through his treatment. So, so first of all, getting back to assessment is so important, actually understanding the patient's situation. And I'd also say social isolation is a really big factor for a lot of our patients. And just because a person's older and maybe reaching the end of life doesn't mean, like often people, I think, and it's getting back to this ageism thing that, oh, it's terrible, the person's young, they've got cancer. It's really terrible when a person's old and has cancer too. Cancer is not a very nice thing. So I just want to discuss a little bit about depression and anxiety. When we do our assessments with our patients, we well, first of all, before we introduced enhanced supportive care, we used the distress thermometer and the problem list. And I often notice that a lot of our older patients would put 0 to 1 to 2 distress, which means, as a validated tool, if the distress is under 4, we wouldn't have followed up with them. So that, first of all, means that all those other practical issues weren't really taken into account. So then with the enhanced supportive care assessments, we have the distress score on there. So 0 to 10, what is your level of distress out of 10? And then we also ask, we have a depression scale with 5 different questions that we ask. So we ask, are you basically satisfied with your life? Do you often get bored? Do you often feel helpless? Do you prefer to stay at home rather than going out and doing new things? Or do you feel pretty worthless the way you are now? And some of those are quite confronting questions. But I think they're really important questions because we do have patients who score quite high on some of those. And so it's really important to be able to make sure that they're being cared for in this area. So we have counselling services that we can refer to. Sometimes the wait time jumps out a bit, and then we will refer to the Cancer Council for it. But I think acknowledging, levels of distress and depression, and then potentially, referring on to other specialists or GP to, be able to work through some of this, some of these feelings of depression, anxiety. But I think for this particular patient, he was very stressed when he arrived here, and I think knowing that there was supportive care, that there were a team, there's a couple of us in this role who could get alongside him and support him along the way, it made a really big difference for him.
Great job, Nicole. That's incredible enhanced supportive care. That's fantastic. I'll make one little comment before I come to Christopher about literacy, which is also a big passion of mine. But it is important to remember that only about 1/3 of men and 1/4 of women over the age of 65 will have what we call level 3 literacy, which is defined as a competent functional ability to use reading, writing, and communication skills in everyday situations, work, and study. So when we're giving people what many would consider impenetrable documents regarding toxicities, we really are assuming that people are able to digest that information when oftentimes they cannot. And we need to think about innovative ways to deal with that. Christopher, onto one of my favourite topics. Older individuals may very well devalue their own health and their needs when discussing cancer treatment. And as we've discussed many times, this is a form of ageism called internalized ageism, where people can truly devalue themselves. Is that something you've come across clinically?
Yes, well, the concept of ageism, as you say, is multifactorial, and internalized ageism is prevalent and is potentially one of the most difficult forms to deal with. My favourite AI tool at the moment, Perplexity, describes internalized ageism as occurring when older adults themselves adopt ageist stereotypes, resulting in negative self-perceptions, reduced healthcare seeking, and lower expectations for their care and outcomes. And we know there's evidence to suggest that this approach alone can result in lower healthcare outcomes in general. So ageism does have a direct negative impact on patients and their care. And this is quite apart from the other forms of ageism: interpersonal ageism against each individuals, institutional and structural ageism, where institutions apply ageist principles. The Perplexity also talks about explicit and implicit ageism, conscious and unconscious, and it also describes one I'd not heard of before, but you might have been alluding to it, was benevolent ageism, where actions which are meant to protect older adults, like recommending less intensive treatment, ultimately limit their choices or autonomy. So as you can see from each of those different forms, a strategy to address ageism requires a multifaceted approach. Of course, the things that we can do simply is recognise ageism exists, and Kristen Haas's scoping review of ageism cancer care has shown that we know it does exist and is prevalent in oncology treatment facilities and in the cancer care world. But the ways that we particularly address it as an individual is, number one, recognise it, and number two, call it out, and number three, use appropriate language, because ageism is embedded in the language that we use, and one of the simplest things we can do is to, as you know well, Michael, is use appropriate language. So we're no longer using the word elderly. We're no longer referring to a patient as geriatric, for example. So older adults and older people are the terms we should use, and that's just simple. We should avoid negative stereotypes where possible. And I no longer have the slide of the tsunami of older people coming towards us in my presentations for this reason. We don't refer tsunami as a negative term against these issues. So there are a number of ways in which I think we can combat this problem. The tool that we've studied in our research here that helps determine what matters most for the patients as part of what we call age-friendly care, which, let's face it, if we can do that in a systematic way, we should be able to avoid ageism, is the This Is Me tool, as Nicole mentioned, was developed by the team at Peter Mack and Maya Krishnaswamy. And in that, it's got sections in its second iteration about what's important to me and what's and what matters most. And we're asking distinct questions of the patients to help us guide therapy in that regard. And by identifying these issues and identifying these factors of our patients, I think we can help combat ageism and get a better picture of our patients at the same time.
Thank you, Christopher. And very exciting news, the optimal care pathway for managing older people with cancer is soon to be publicly available. You had a very instrumental role to play in that, and thank you for all of your endeavours. And I know Shalini and I were very involved in that as well, and that's going to be a huge contribution, I think.
It was a team effort, Michael, from the COSA and everyone, and absolutely, I was going to say the optimal care pathway as a tool of advising optimal care at institutional and personal levels for our patients will help combat ageism, I'm sure. But it's a multifaceted approach with and we've got lots of work to do, as you well know.
Mm. And you've brought up that institutional space and that interpersonal space really well. And I think it reflects the fact that we do all carry ageist attitudes. We know that ageism is associated with a 7.5-year decrement in survival. And I wonder, Shalini, if you could tell us a little bit about the forms of ageism that you may see in your clinics and how we can approach that.
Yes, so I think, Michael, you said right at the beginning that ageism is really related to how we think about, feel about, and act towards older individuals. And that may be us as clinicians, but it's also all the staff at the center, you know, from the receptionist meeting the patient to the treating staff to, you know, people in the corridors who work in the hospital. And I do see, you know, some of our staff not recognizing that older patients may have special needs, may need a bit more time to mobilize, or can't hear as well, or may not be able to read. There's a lot of presumptions, and I think sometimes the staff are not taking that into account, and that can lead to, you know, miscommunication and just a poor experience for the patient. I guess in terms of the clinicians, we might also make some assumptions in that older people, you know, may not want to make treatment decisions themselves. They might, we might speak to the carers rather than the patients, and indeed that might exist, particularly in some cultures. But I think we have to be very careful to work out: is it the patient, the carer, or it might be a sort of collective group decisions. And which is perhaps slightly different for a younger patient who will, you know, take things in, feel like they want to be the one in control in terms of the decision making. We might also make some presumptions regarding, you know, quality of life versus length of life. We might presume that it is quality of life that drives decisions, and that might make us not perhaps discuss some of the more aggressive treatment regimens, but unless you ask, you won't know. And sometimes older patients may seem very passive in their decision making, but if we don't ask about any sensory issues in terms of sight and hearing, it might simply be that they're not comprehending all the information, they're just being quiet. And so unless you ask about these things, you're not going to realize that they exist. So I guess, you know, in terms of how I manage these issues, I certainly do use some tools. I use the G8 that Christopher mentioned, but I also use, I ask the patients to fill in that ASCO patient questionnaire, which includes those 5 questions that Nicole talked about, to screen for anxiety and depression. However, I guess one limitation in my practice is that only works for English-speaking patients. And I don't have the sort of time or capacity to perhaps ask all those questions with an interpreter there after I've had the full clinic consultation. So that is a slight limitation. But in terms of the English-speaking patients, it's my registrar often gives it to them to fill in while they are talking to me. And by the time I see them, I've got that information, I've got the cancer information, and then we can take all that into account in developing a management plan. I think it is really important to ask the patient, you know, what is your goal? What do you want? And that might be something as simple as, you know, I want to live to I don't know, see the birth of a grandchild or a wedding anniversary, or I want to live long enough to do this, or no, it's all about quality of life. I want to stay out of hospital. I want to maintain independence. That's really important to ask because that'll influence what I recommend. I do have older people attending by themselves, and that always worries me. So I do ask if they would like to have a family member on the phone, so they've got someone else to listen or hear that conversation, or if they'd like to record it. The other thing I do, you know, apart from providing written information, the letters I write, actually, the copy goes back to the patient. Bearing in mind, I guess, the health literacy, but at least the copy is there. So if a family member who was not present wants to look at what I've written, but it is still going to have medical terminology, but at least, you know, I've got the treatment plan there, and then they can ring me. So these are some of the ways I try and help, but no system is perfect. And gosh, you know, if someone doesn't speak English and we've got interpreters, there's an added complexity which makes it even more difficult.
Thank you so much, Shalini. I think my letters may be a touch too casual for patients to see, but I'm very impressed with yours.
And Michael, I'll just say I've got an iPad on my table that I use to bring, not just phone calls, I have video calls with the relatives where possible. And I'm pleased to announce Nicole and the Community Cancer Centre, the community organisation that funds a lot of the work in our cancer centre, have provided me this last week with a personal amplifier. And I've used it and I've seen it for the first time. So it's just basically a headphone and a microphone, but a great quality one. That then I was, in my patients with hearing impairment, I was able to communicate. And the change in the body language when the person could actually see me was amazing. So simple tools to enable that communication, recognising a hearing impairment is a real thing in our patients. I can't state how important that is and how simple this manoeuvre was. Get a personal amplifier and use it.
Yeah, that's a great practical tip. Thanks,
Can I
Christopher.
just add one thing to that?
Of course.
I'm also very excited about these personal amplifiers. I did an assessment on a patient a few weeks ago who had bilateral hearing aids, and he still couldn't hear me properly. So he was my very first patient that we tried the amplifiers on, and it was like Christopher says, the body language just changed. He sat back in his chair and it felt like the whole assessment was so much easier. Yeah. I had to just talk quietly though, because they're quite good.
I think I would appreciate the opportunity to look like Madonna with one of those on. And look, Nicole, we're going great for time. I'm sure we're not, but I think we're going great for time. And I guess I want to end with a pretty big question, which is that around stigma. And Shalini's already mentioned this sort of intersectionality that can occur with an older individual who may come from a culturally and linguistically diverse background. But unfortunately, patients with thoracic cancers can also feel stigmatized just because they've got a thoracic cancer. And I guess I'm wondering if you could tell us a bit about how older people may experience stigma.
Thanks, Michael. I think lung cancer in general, lots of people experience stigma no matter what their ages are. With our assessment, our enhanced supportive care assessment, one of the questions we ask is, have you smoked over 100 cigarettes in your lifetime? And I have very few patients who say no. I would say the vast majority of patients who are older have smoked over 100 cigarettes in their lifetime. And one of the things I'll often say to them is, we really just didn't know. We didn't know how bad smoking was back then. And I also am very quick to say to patients who are still smoking, it's a really hard thing to give up. So stigma is basically, a negative label or an assumption. And I think I've worked with a lot of lung cancer patients who have been very ashamed of their lung cancer and have sort of felt that they've brought it on themselves. And so there is work to be done on, helping them understand that, first of all, we didn't know smoking was bad for you. People smoke for various reasons, and some of that is stress and anxiety, and we're not here to judge. But I think, it's just really important that people do know, that our old people that we work with know that it's happened. We can't change it, but that there is also some help. So we do have programs, and a lot of the time I have patients who have quit who no longer smoke. But I think that stigma can have various implications, like, maybe feelings of, I'm not really worthy of the treatment because it's my fault. And sometimes it that may delay people from actually coming to medical oncology. So that's probably what I'd say about stigma. But I think also that intersectionality, I think as an older person, there can be a lot of stigma just generally. And, we've talked quite a bit about ageism, and Christopher touched on internalized ageism, but I think that crossing over of a lung cancer and being older, there can be complexities there. I would like to say too, I have patients who have never smoked who get lung cancer and are very angry about that. That's a whole different conversation, really.
Yeah. Thanks so much, Nicole. And you've touched on something that I say to patients all the time, which is I have the great privilege of not having to judge. And that is one of our great privileges in medicine, that we get to exist in a world where we don't have to judge patients. Look, I really, really, really want to thank all three of you for joining me today. It's been an extremely wonderful conversation, and I've just been jotting down a few notes as we've been going, I guess, as sort of main messages. And one of them that I've written here is open minds and open conversations. That when a person comes to see us, young or older, we should always have an open mind to the possibilities available to them for their cancer, and always have open conversations with them and with their carers and with their loved ones. And I think that leads to my second point, and I'm not sure, I think this is an amalgam of everything you've said, which is don't make assumptions about older people and provide the sort of comprehensive care that you would want a family member to receive. And that is such an enormous privilege we have, and I hope something that those listening take on board. That brings us to the end of this episode. Thank you so much to Professor Christopher Steer, Professor Shalini Vinod, and Ms Nicole Webb for joining us during this fascinating discussion. As always, thank you to those listeners, and thank you for listening to TOGA's Conversations in Lung Cancer Research. If you've enjoyed the show, please rate and review us on Apple Podcasts or on Spotify. Again, thank you to everyone for listening in, and I hope we've made fervent geriatric oncologists of you all.